there.
Yeah, thank you for the introduction. I'm excited to be a part of this conference among this distinguished group of clinicians and researchers. So I will be presenting part of my dissertation work titled Cost Effectiveness of Esketamine Nasal Spray compared to intravenous ketamine for patients with treatment-resistant depression in the United States, utilizing clinical trial efficacy and real-world effectiveness estimates. I'd like to thank my primary advisor, Professor Dan Malone, as well as Dr. Reed Robinson for providing guidance and mentorship with this study. So a bit of background on major depressive disorder. As we know, it's one of the most common mental health disorders in the US and a major cause of disability. It also carries a significant cost burden near $210 billion in the United States. Treatment-resistant depression is broadly defined as failure to achieve a response or remission to at least 2 antidepressant medications. These patients account for about a third of MDD patients and disproportionately account for the burden of disease caused by depression. So pharmacotherapy options for TRD are pretty limited. Patients can switch or combine antidepressants, utilize second-generation antipsychotics, or augmentation with lithium. However, most antidepressants take several weeks to start working, and risk of suicidal ideation or attempt may be imminent. Thus, there is significant unmet need for rapid-acting antidepressant medication. So as we have seen so far with this conference, ketamine and esketamine offer this novel treatment. They're the first non-monoaminergic agents with rapid reduction of depressive symptoms as early as 24 hours post-administration. So I wanted to give a little bit of background on the cost of ketamine and esketamine specific to the United States, given that this is an international conference. So ketamine clinics have opened across the US to provide ketamine for mood disorders. And patient costs per infusion can vary anywhere from $295 to $1,000. And the patient must pay this entire cost out of pocket because ketamine for depression is not covered by insurance because it is not an FDA-approved indication. On the other hand, esketamine nasal spray developed by Janssen Pharmaceuticals was approved by the FDA for TRD and thus can therefore be covered by insurance under a medical or pharmacy benefit. However, at its current list price, it is substantially more expensive than other antidepressants, between $590 and $895 per treatment. However, these costs do not consider insurance coverage or copay assistance programs. Therefore, the cost of esketamine from the patient's perspective in real-world practice may differ substantially from current estimates. So my research aims were to quantify the cost effectiveness of esketamine nasal spray compared to IV ketamine for patients with TRD in the United States, estimating quality adjusted life years, cost in 2020 USD, and incremental cost effectiveness ratios. I wanted to utilize both clinical trial efficacy as well as real-world effectiveness estimates, running the model 2 versions with the efficacy and then the effectiveness. I utilize a time horizon of 3 years to allow adequate time for cost benefits to accrue without extrapolating beyond 2 years from available data. I conduct the analysis from both the healthcare sector perspective as well as the patient perspective, which included cost of patient time and patient copays. And I use a discount rate of 3% for future costs and qualities. And I created and performed the analyses in Triage Pro Suite. So my outcomes of interest were response, which was defined as proportion of participants who achieved a minimum reduction of 50% in their baseline depression score, relapse from response, quality adjusted life years, and all-cause mortality adjusted for the increased risk of mortality for people with depression. So this is an overview of my decision analytic model structure where I created a Markov cohort model with a 1-month cycle length. And patients enter the model upon initiation of treatment line 3 because this is a typical definition of TRD. And after the first cycle, patients can transition to one of 3 hub states. From response, patients could stay in response, they could relapse or transition to death. From non-response, patients could transition to response, stay in non-response, or transition to death, and death is the tunneling state. So quickly going over my input parameters. So I had that annual mortality probability obtained from the US life tables, applying the increased risk of mortality for patients with depression. My time horizon and the utility values were obtained from a prospective cohort study that utilized the Euro Qualified D to assess the quality of life of patients with MDD. So here are my efficacy and effectiveness estimates. For the clinical trial efficacy estimates of esketamine, I utilized the data from the large-scale phase 3 RCTs of esketamine to determine the relative risk of response and relapse that I then converted to monthly probabilities to utilize in my model. For the clinical trial efficacy estimates of ketamine, I utilized the data from a meta-analysis by Mark and Tony et al. That assessed the efficacy of IV ketamine for TRD specifically. I conducted my own meta-analysis of the data included in that study to determine the relative risk of response to ketamine that I then converted to a monthly probability for my model. And I assumed equal relapse rates for ketamine and esketamine because there's not available data in the literature for ketamine treatment for TRD for long-term to assess relapse. And the effectiveness estimates came from real-world patient data. I utilized electronic health record data from a private outpatient psychiatric clinic to determine the percentage of patients with TRD that achieve response with either esketamine or ketamine treatment. The standard error of response rate was calculated using the binomial distribution. And because longer-term observational data was not available, I utilized the clinical trial estimates for relapse from response. So here are my model inputs for cost, where for both ketamine and esketamine, the patient would have a physician visit at each dosing session. And and this is an assumption of the model. And the cost specific to esketamine provision included the cost of medication, as well as cost of 2 hours of medical assistant monitoring, which is what is required by the risk evaluation mitigation strategy. And for the cost of esketamine, I utilized IBM Redbook's wholesale acquisition cost for the 28 milligram device. And the cost specific to ketamine administration included the cost of medication, which I again obtained from Redbook's wholesale acquisition cost, the cost of 75 minutes of medical assistant monitoring, and IV supply cost administration. And for both esketamine and ketamine, I assumed that one MA was monitoring 4 patients at a time. For the patient perspective, we included cost of patient time and replaced the cost of the physician visit and medications with patient copays. We utilized these patient copays because we wanted to estimate the total net out-of-pocket payments for medications as a drug cost measurement and as the physician visit cost. So esketamine medication copay was assumed to be $10 in the base case analysis based on the manufacturer's copay assistance program for commercially insured patients. And I varied this copay based on the average prescription drug copays for individuals with employer health benefits in the US. And for the ketamine patient copay, I utilized a low estimate of IV ketamine administration for clinics in the US that administer ketamine, and I varied this in the sensitivity analysis. We assumed that esketamine treatment would require 3 hours and ketamine treatment would require 2 hours and 15 minutes, where this includes dosing, monitoring, and travel. And I utilized average hourly earnings of US adults to calculate that cost. So this is an overview of the treatment schedule that I use in my model, where dose and dose frequency of esketamine was based on the product's prescribing recommendations and the FDA-approved labeling. It's given twice weekly in month 1, where you have an escalation of the dose to 84 milligrams, and vary this in the sensitivity analysis. In response, it's given once weekly at 84 milligrams. In non-response relapse, I assumed is giving twice weekly, all doses at 84 milligrams. The dose and dose schedule of IV ketamine was based on consultation with clinical experts, and I used gender and weight-based dosing to estimate the total milligrams of ketamine given per visit. And I assume that was given twice weekly at a starting dose of 0.5 milligrams per kilograms and increased to 1 milligrams per kilograms thereafter. And similar to esketamine, given once weekly in response and twice weekly in non-response or relapse. I also performed one-way and probabilistic sensitivity analyses to determine the impact of model parameter uncertainty and variability on our results. And I will just be going over the PSA due to time, where I performed a second-order Monte Carlo simulation with 10,000 iterations based on the distribution of variables. So going over the base case results utilizing the clinical trial efficacy estimates. So ketamine and esketamine had a small difference in QALYs or effectiveness, just 0.05. However, under the healthcare sector perspective, esketamine was substantially more expensive than ketamine. And this was largely driven by medication costs, as can be seen here. And when you have a therapy that is both more costly and less effective, it is said to be dominated. And for those of you unfamiliar with health economic studies, we have the incremental cost effectiveness ratio of the change in cost over change in benefits. And that's what's here. So yeah, when it's negative, it's dominated. So esketamine was dominated by ketamine under the healthcare sector perspective. Under the patient perspective, we have ketamine being more expensive than esketamine. And this again was largely driven by medication costs. And we have this large ICER value of close to $900,000 per QALY. And this is inflated due to that small difference in QALYs in the denominator. So with the real world effectiveness estimates, we have similar results, an even smaller difference in QALYs between esketamine and ketamine. Again, esketamine is substantially more expensive under the healthcare sector perspective, leading it to be dominated by ketamine. Under the patient perspective, ketamine is more expensive, leading to this very large inflated ICER value with that 0.01 in the denominator. So before I review the probabilistic sensitivity analysis, I just wanted to go over the cost effectiveness plane, where you have the effect difference on the x-axis and the cost difference on the y-axis. And when a therapy is either more costly, more effective than the therapy you're comparing it to, or less costly, less effective, you have a trade-off between those two therapies. When a therapy, as I mentioned, is more costly, less effective, it is dominated. And when a therapy is less costly and more effective, it is dominant over the comparator. So looking at the PSA with a clinical trial efficacy, under the healthcare sector perspective, I utilized a threshold of $150,000 per QALY, as that's the typical upper bound of cost effectiveness analyses in the United States. And there were no scenarios in which esketamine was cost effective compared to IV ketamine. Under the healthcare sector perspective, all these scenarios are in that quadrant 4. Under the patient perspective, esketamine is less costly and less effective in the majority of scenarios. And the probability that esketamine was superior to ketamine was just 0.55% of simulations. And this graph is in that quadrant 3 right there. So when we look at real world effectiveness, it is similar to that clinical trial efficacy results, where there were no scenarios under the healthcare sector perspective that esketamine was cost effective. However, under the patient perspective, the probability that esketamine was superior to IV ketamine was 35%. And the rest of the scenarios, esketamine was less costly, less effective, and above the willingness to pay threshold of $150,000 per QALY. So overall, in this decision analytic model evaluating esketamine compared to ketamine for TRD, we found esketamine is unlikely to be cost-effective compared to ketamine at $150,000 per QALY. Under the healthcare sector perspective, esketamine was dominated by ketamine with both versions of efficacy and effectiveness. And in uncertainty analyses, esketamine was likely to be cost-effective compared to ketamine only under the patient perspective. So essentially, the cost-effectiveness of either medication depends on the perspective utilized. From a healthcare sector perspective, effort will be required by payers and policymakers to reduce esketamine's price to reach a value-based price. With similar effectiveness, ketamine may be the preferred choice to treat patients in a cost-effective manner. However, when considering the patient perspective, esketamine may be preferred since TRD is an FDA-approved indication. Thus, patients receive insurance coverage for the medication. So shared decision-making with patients and providers will be necessary to determine which treatment patients can access and afford. So quickly, some of my limitations. The data we utilize for efficacy estimates have several limitations, where these ketamine trials conducted in a few hundred participants. The IV ketamine trials were conducted in a total of 118 participants, did not have longer-term observation of clinical data. My 3-year time horizon may have failed to capture longer-term costs and benefits. However, when I varied this to 5 years, my results were robust. And the analysis excludes potentially important benefits to families and patients, to families of patients with TRD and to the broader society. And it was assumed that patients follow a similar and consistent pattern of treatment following relapse, which may not represent actual treatment patterns. And that's it.
Time for 1 or 2 quick questions. Any questions from the audience? Okay, I have a question for you. Sorry.
Thanks very much, Madeline. It's Bartek here from Centre for Affective Disorder at King's College London, Alan Young team. So I was always wondering about this cost-effectiveness analysis, that the one factor has not been taken, and when I see it similar with NICE review, accessibility. Yes, ketamine is much cheaper because nothing compared to esketamine. But to set up a ketamine, it requires so much. For instance, there's only a few clinics for the whole of the United Kingdom. And if you put that, so there's low access to those treatments in depression. Let's say if you introduce an innovation, which is a small plastic device, which is a micro hospital at the hand, a healthcare assistant in Shetland Islands or Manchester or wherever, just talking about very remote places, can deliver this advanced treatment tomorrow. So, and I think then the loss of accessibility for this patient is another sort of a bigger health economic loss. What do you think?
What exactly is your question? So you're saying that like esketamine is more accessible because it's less difficult to like set up in a healthcare system?
Do you factor in the accessibility of the treatment to the patient, such that intranasal device is much easier to give than the IV infusion?
You know, I feel like that would be assessed more with like a societal perspective with the CEA, where, I mean, I could definitely like look into adding that on. With the patient perspective, I was just really concerned about what are their like total out-of-pocket costs. So I wasn't, I didn't take into account the accessibility portion of it, but that would be important to include.
Okay, thank you very much. I'm afraid we have to move on to the next speaker. Thanks very much.
Thank you.